morning, everyone. Today I'll be talking about standalone cage versus anchored cage and comparative analysis between the clinical and the radiological outcomes. So Smith and Robinson first introduced this technique in 1958. They performed ACDF using an anterior approach, and they used iliac crest bone grafting for the same. Since then, this technique has evolved, and today we see a much different picture. So I'll go briefly through the evolution of the cages. Initially, Smith and Robinson, Bailey Badgley used iliac crest bone grafting. However, this had high donor site morbidity and also high rates of subsidence, which led to recurrence of symptoms. Following this, we had the advent of the cage and plate method. However, this method also had its own share of disadvantages, like the cage backout, esophageal irritation, and at times esophageal perforation too. This led to the advent of the standalone cage. So the standalone cage was initially a carbon fiber cage, followed by the advent of the titanium cage, and currently what we see most commonly used are the PEEK cages. This is the anchored cage, which is the most recent introduction to these cages. So the aims and objectives of my study are to assess the clinical outcomes between standalone cages and the anchored cages. We conducted a prospective non-randomized analysis for patients undergoing ACDF between 2017 to 2021 at a single tertiary care center operated by 3 experienced surgeons. Our sample size included 62 patients. We included patients undergoing single and double level ACDF and excluded patients who had infection, tumors, traumatic fractures, or who were undergoing revision surgery. We clinically assessed the patients using the MJOA for myelopathy, the VAS score for pain, the SF36 score, which is a health survey questionnaire, the NDI to assess the day-to-day disability of the patient, and the Bahar score for post-op dysphagia. Our radiological assessment included the global and cervical global lordosis and the segmental lordosis that was calculated using the Cobb's angle. We also calculated subsidence and cage migration. Subsidence was calculated as more than 2 mm decrease in the anterior or the posterior disc height. Cage migration was calculated as the change in distance between the anterior tip of the vertebral body and the anterior tip of the cage by more than 2 mm. So these are our outcomes. The anchored cages showed a statistically significant improvement in the pre-op and the post-op group. So did the standalone cages. However, we did not find any statistically significant difference between the two groups, that is the standalone cage and the anchored cage. Our global lordosis also showed a statistically significant pre-op and a post-op difference, as did the segmental lordosis. However, there was no difference between the standalone cage and the anchored cage group. One of the important findings of our study was the cage subsidence. 4 of our cases in the standalone group had subsidence compared with 2 in the anchored group. And 51 of our patients had mild post-op dysphagia, but none of them complained of sustained dysphagia in their follow-ups. Going through a few examples, on the left we can see an example of a standalone cage, and on the right an anchored cage, the pre-op and the post-op x-rays. This is an example of a 45-year-old gentleman who underwent ACDF with a standalone cage. We noticed subsidence at 1-year follow-up for this patient. However, the clinical outcomes were not hampered. 4 of our cases underwent cage migration. So to conclude, subsidence, we noted subsidence in 13% of our cases who had undergone ACDF with standalone and 6.8% with anchored cages, and was most commonly observed due to superior end reach. The results of our study are comparable with the other literature that we have reviewed, and the most common cause of subsidence is over-distraction or end plate damage. The limitations of our study were noted as it was a non-randomized cohort, and we did not note any correlation with the confounding factors. To conclude, anchored cages have a slight advantage over the standalone cages in lowering subsidence. However, the clinical outcomes do not differ at the 1-year follow-up. Thank you.